Hi everyone. Welcome to our MND Academy webinar, and thank you so much for joining us today on a Friday afternoon. Our topic today will be multidisciplinary and holistic approaches to supporting people with motor neuron disease, looking at this through from diagnosis to end of life. So I'd like to say a big thank you to our sponsor. This webinar has received sponsorship from Zambon UK Limited. The first session in the webinar is designed and delivered by the MND Academy and sponsored by Zambon UK Limited. The sponsor has had no input into the educational content or organisation for this session. The second session is a satellite symposium that is designed and delivered by Zambon UK Limited. So just before we start on the webinar, I just wanted to mention this on-demand piece of education which is now available. It's being led by Dr. Ed Richfield, who is an elderly care physician and academic lead for the Palliative Care Academy, and myself. The education is designed to support clinicians in understanding the assisted dying bill, exploring the legal, ethical and spiritual and professional discussion and supporting patients, carers, colleagues and others. I think particularly ourselves. So I wanted to mention it. Here's the link to sign up. So just looking at the timeline, the first part is the MND Academy webinar from 3 o'clock for 45 minutes. We will have a short break and then the Zambon Satellite Symposium, which will be from 3:50, which will be on optimizing ALS care, practical approaches to oral management, and this will be led by Dr. Rafael Di Bioso, who is an Associate Professor of Neurology from Naples. So for by way of introduction for myself, my name is Ruth Stross. I'm Head of Nursing with Neurology Academy, and joining me today is Dr. Pablo Garcia Reitbach, who is a consultant neurologist at St George's Hospital in London, and he's Honorary Senior Lecturer at St George's University. He also has a specialist interest in motor neuron disease. Judy Newton, joining us as well, is an MND National Nurse Consultant who is working in Scotland, and she is Deputy Director for the Anne Rowling Regenerative Neurology Clinic. And also with us today is Dr. Emma Husbands, who is a consultant in palliative medicine, working across the community in Gloucestershire, and is also part of the lead faculty for Palliative Care Academy. So thank you to the speakers for joining us today. So in this 45 minutes, we will aim to cover best practice in consultations at a diagnosis of motor neuron disease, practical approaches to holistic multidisciplinary care throughout the disease course, and looking at the complexity of supporting people with MND across all domains of dysfunction and support that is required. Just a reminder, please do use the Q&A function if you have any questions throughout this webinar. All of the speakers have said they would really welcome questions, and we're hoping to have some time at the end to be able to go through this. So without further ado, I'd like to hand over to Pablo. Thank you.
I hope you can see my slides now. Yeah. Okay, so my name is Pablo Garcia Reitbach. I'm a consultant neurologist at St George's Hospital, and together with Dr. Claire Galtrey, we run the motor neuron disease clinic there for patients in Southwest London and Surrey, and we're part of the Southwest London MNDA Care and Research Network. So I'll just be talking what we go through in the initial consultation in our MND clinic. So the first thing we do is we review the history and of the patient. We go through the history in detail. We review previous letters. We examine the patient carefully, and we look at the results. And patients are referred from different sources. So most of the time they will come from secondary care, so from district general hospitals in the region, either for a second opinion or because patients were already diagnosed with motor neuron disease, and then for onward management. And discussions afterwards will depend on what was discussed with the patient in the community or in the secondary care hospital. So after reviewing the records and examining the patient, taking the history, if we're able to confirm the diagnosis or make a diagnosis, we will do that. It can vary what patients know about motor neuron disease. and what they have been told in the past with seeing a neurologist in other hospitals. So we will tailor this to the patient. The patients will know they've got motor neuron disease, who will have read up a lot about motor neuron disease, and basically want us to follow up or have sort of more in-depth explanation of patients who know nothing about motor neuron disease. And that's sometimes a bit challenging, how to give the diagnosis to the patient and how to do this sensitively. I would always ask the patient how much they would want to know about motor neuron disease, what they already know, so that I can gauge how much information I give them and how I give them the information. And sometimes that can be challenging. There's a lot to discuss about motor neuron disease, so the impact on respiratory function and need for monitoring, nutritional management, weight loss, and how to manage this in the community, what medications we can offer to patients with motor neuron disease, what effect they have, what side effects, sort of the nature of MDT care. This is sort of a team effort to look after patients with motor neuron disease together with the community therapy team, and also our motor neuron disease coordinator in the clinic. Advanced care planning will, at the initial meeting, maybe mentioned, but not discussed in detail. We also sort of mentioned genetic testing and clinical trials, and we'll talk about this more in the subsequent slides. Liaison with community therapy teams in our area is critical, and we explain sort of the concept to the patients that we're sort of in close contact with community teams. They will review the patients, usually in their home, and feedback to us in MDTs. And we signpost the patients to resources from the MND Association, who have sort of a lot of information on their website and also printouts for patients. Sometimes there are challenges at these initial appointments. So there can be diagnostic uncertainty. For instance, when there's very slow progression, when it's not typical ALS, but other forms of motor neuron disease are more slowly progressive. There's some patients where the disease initially is very localized, maybe just to affect the speech, swallowing very mildly, and it will take some time for us to confirm it. And that's sort of difficult to gauge sort of how much to tell the patient, and is something that I sometimes still struggle with, to be honest. Sometimes we see late presentations, and these are patients who may have been diagnosed in hospital during an inpatient admission and then discharged, but haven't really been followed up by neurologists in outpatients locally. So they're not known to neurology. And then eventually someone in the community will realize that they're not under active follow-up and refer them. And that presents challenges because patients then might have significant speech and swallowing problems, significant respiratory problems, or have lost a lot of weight, or sometimes might not be able to come to clinic because they're bedbound, in which case we can offer video consultations. So that presents challenges. And what I find a particular challenge in clinic is when patients are not prepared for diagnosis. So either they haven't been told before that it might be motor neuron disease, or they lack understanding of the condition, and are not aware that this is a terminal illness. And that's sometimes very difficult then to know how to discuss this, and it needs to be done very sensitively. And I'm still learning how to do this in the best possible way to minimize sort of distress for patients. We will discuss research trials, and over the last years, we've grown as a research center. Judith is in the seminar, and it's largely due to MND Smart, who helped us, MND Smart trial network, who helped us grow as a research center. So there's thankfully an increasing number of clinical trials available to patients with motor neuron disease, and we have sort of more people power to be able to enroll patients into trials. The motor neuron disease research networks, including in European networks like TRICALS or NCALS, and also now the UK MND Research Institute. There are platform trials like the MND Smart trial, which is sort of run by Edinburgh University, and Savanka Palan, Siddharth and Chandran, and Judith and colleagues. And this is sort of a relatively new concept of a trial that doesn't stop after a certain time usually trials need a few years of setup, then they run for 2-3 years, then they get analyzed, and then you have to start from scratch. But here, this is in a way a never-ending trial until we find a treatment that works for motor neuron disease. So it's an innovative trial, and it means that constantly new drugs can be tested and discounted if they don't work. We also offer commercial trials from drug companies. We've recently had an early phase study with an immune drug, so this is very exciting. And the Motor Neuron Disease Association has also recognized the importance of clinical trial delivery, and we now have an MNDA research nurse who helps us with patient engagement to ensure equity of access to trials. These are just a number of trials we've been involved with. So I've just mentioned this early phase study with a TREM2 antibody, which works on the immune cells of the brain called microglia. We've recruited one patient. Expert ALS is sort of a human drug platform, if you want. So we can usually drugs that are tested in a dish and then tested in a large trial. But this sort of tests compounds in patients with motor neuron disease to see if there's an early signal where this drug might work. The MND SMART trial has really helped us grow as a center, so I'm very grateful for that. And we've recently completed this lighthouse study that looked at the role of retroviruses in motor neuron disease. I've just put these two newspaper articles or publications up here to see that there is significant advance in treatment of diseases that were previously thought to be untreatable. So we now have a treatment for a genetic form of motor neuron disease called SOD1, which is being offered as part of an early access trial. And last week, there was a gene therapy who has shown extremely promising results in patients with Huntington's disease. So there's progress, and I think it's very important to be able to be part of that and offer patients the possibility to find a cure for this terminal illness. Genetic testing has really increased in our clinic, and this is mainly due to the fact that there's now early access treatment called tofersen for the SOD1 genetic form of motor neuron disease. I mean, this is a very rare form of motor neuron disease. I would say less than 1 or 2% of all patients will have this gene. But because of this, lots of patients now want to have genetic testing. Counseling is really important because we can only test for all the genes that are known to cause motor neuron disease, not just for SOD1. And then that has implications for their families and for themselves as well. So it's important to counsel them. And we have a genetics nurse who can counsel patients in a separate consultation. Interpretation of the results can be tricky as well, and so we need to warn patients about this as well. In terms of treatments, we can offer riluzole. That's the only drug so far to have shown to slow down the disease. It has sort of a modest effect, but I also don't want to downplay it. So if you look at the trial results from a trial in 1994, it has sort of reduced the risk of death by 35%. And the 1-year survival was significantly increased. So it does have an effect, but it is modest. Non-invasive ventilation is another way for patients to be able to prolong their life or improve the quality of life because it makes them feel stronger during the day. And that's been shown in this trial in 2006. Nutrition and weight management is really important. And we know that patients who lose a lot of weight do worse and have poor survival. So we manage this as well. And then there's symptomatic treatments of secretions, cramps, and pain that we can also offer. And with this, I'm finished, and I'll hand over to Emma.
So yeah, I'm Emma Husbands. I'm one of the palliative medicine consultants in Gloucestershire. I work across the community. So we are a large county, actually not a tertiary centre for MND. We work with various other tertiary centres, but largely in that hub and spoke model that a lot of people will be working in. And that ongoing support for patients is tricky to describe in the sense that MND services are varied across the whole of the country. But we know that with that MDT being so vital, establishing your understanding of your local structure, your points of contact, your phone of friends is probably one of the most important things that you can do. And with the specialist palliative care role, that is also going to be variable, because we know that many MND coordinators, ANPs, CNSs, team members might have a specialist palliative care background. They might have a neurology background. So their skill set is going to come from slightly different angles at times. And specialist palliative care may well be fairly integrated in almost an early supportive care model within the MDT, within our structure in Gloucestershire. It's not uncommon that I will see patients quite early at the point of diagnosis to be able to start having some of those conversations. And there is not enough time to talk about symptom control today, but there are lots of resources available through the NICE guidance, updated in 2019, and the MNDA website, with a really good range of resources for not only patients and their families, but also for healthcare professionals. And I'd encourage you to look at those. And often that is giving you the starting point for those common symptom issues. And specialist palliative care might well then come in to give some recommendations around the more unusual symptom control measures. I've just picked a few here. Pain and cramps, we know, probably under-recognized at times in MND, potentially anything up to about 90% of people do experience that. Magnesium creams topically, Celtic salts is something that patients have described to me as being beneficial to them. Nefapam is a preparation that's a non-opioid, non-NSAID, been shown in conditions like Duchenne muscular dystrophy to be a little bit helpful with the musculoskeletal aches and pains. So over and above those opioids, gabapentin, pregabalin, baclofen, standard preparations that you might use. Salivary secretions, which we know are always challenging, anticholinergics often the mainstay. Atropine eye drops tend to ebb and flow in terms of how commonly they're seen, but they seem to be flavor of the month a little bit at the moment, and Botox injections. But clonidine is a different modality, so alpha adrenal receptor activity agonism, and that seems to work slightly differently to the anticholinergics for the more watery salivary secretions, obviously with care over blood pressure. And for the slightly more mucoid secretions, atenolol, once a day preparation, which is quite useful as an alternative to propranolol, which has been used in the past. Pathological emotionality is another topic with under-acknowledged, I think, with patients who live with motor neuron disease. Certainly when I was at medical school, we talked about pseudobulbar affect, and we talked about inappropriate laughter and crying, but pathological emotionality does actually extend into other forms of emotion. So irritability, outbursts of anger, obsessive behaviors, and even into the extremes of apathy. Again, the mainstay of approach to this are things like citalopram, amitriptyline, sertraline, antidepressants. Really clear explanation to families in particular that this is a normal part of MND, and that it's something that isn't their loved one necessarily being irritable. It's something that they can't necessarily control. But again, there are other approaches to that now. Something called dextromethorphan and quinidine is available as Nudexta in the US, and although we can't get that over here in the UK, we do have ways of being able to mirror that, and that can be a really useful game-changing intervention for the stresses and strains of trying to support people living with MND and with that difficult symptom. We use something called the CNS-LS questionnaire, which is a validated questionnaire to have a baseline marker for that. There are also some measures that I know Judy's going to talk about as well. Chest secretions, again, another tricky symptom, carbocystine, saline nebs, cough assist, often a fairly standard approach. N-acetylcysteine is something that's now increasingly an alternative to carbocystine. It's also available over the counter through various websites and so on for people to buy, so sometimes easily accessible. And guaifenesin cough mixture as a chesty cough mixture, also sometimes really helpful. You know, these are very brief, simple examples, but it's trying to think outside of the box of the standard when those standards aren't working. Advanced care planning or future care planning or emergency care planning, whatever you want to call it, is another really important part of the MDT approach. And it's something that needs to run through, as Pablo has already alluded to, the whole of the MND journey. And we know that advanced care planning is underutilized throughout medicine, not just in neurological conditions and MND, but it does. Through that underutilization, we risk the under or the over treatment of people and resultant poor quality of life. And we know that often the underutilization is around those misconceptions over what palliative care means, what the concept and the goal of advanced care planning is. There are fears that we can remove hope by having these conversations, that we can cause distress. We don't like to do that. But actually, the evidence consistently shows that people are expecting clinicians to be leading on these discussions, and also that there is an enhancement in the relationship with a clinician when they do lead on them. There's often a negativity, isn't there, around the conversations that they're end-of-life care planning and their DNA CPR discussions. But these are conversations that are about life and living planning. It's a process of communication. It's developing an understanding of what matters to that individual. For some people, it is a life at all costs approach. For others, that isn't their priority. And if they can't do certain things, then the focus should shift much more on comfort measures alone. So it's a continuum of a conversation. And that's a really important part of the recollection around how we approach advanced care planning. There are different formats. There are informal elements, so a what matters to you conversation, documenting priorities maybe as an advanced care plan, and every area will use different formats of documents. We tend to use the respect plan as an overarching document locally here, but in other places it will be different things. There are apps as well. Documentations around CPR recommendations are not legally binding, remember, so there is an informality to them as well. Formal options, powers of attorney, be they health and welfare or finance, but it is important to distinguish. And clearly some people have really strong views over wishing to document that they would refuse certain interventions in certain situations. So ADLTs can have a really big role. And people might well have some of these things already. You know, it's absolutely okay to ask, have you written a will? Have you thought about organ donation? All of these aspects form part of advanced care planning. And I find it's also sometimes really helpful to talk about the person who is often a main support for people living with MND, particularly with their vulnerabilities. What would happen if Jack, Jill fell ill? What would we be doing? And so it's an all-involved conversation with everybody around that person with MND as much as them. When it comes to important points around advanced care planning, again, because it is a continuum, because it is a process, it's helpful to know what conversations have happened. Has there been any discussions around life-sustaining measures like PEG, like BiPAP, if they aren't already making use of those things? Remembering that where life-sustaining measures are involved, there is the option that people can choose to withdraw. And that is something that we need to keep bringing up at an appropriate interval and reminding people of, so that they do have that sense of control, and we remind them that they are in control of that intervention. Are there any points of contact? That can be really helpful. You know, at 2 o'clock in the morning, is there a neurological advice line? Is there a palliative care advice line for people who may just have that little bit of detail around that individual? What fears do they have? What values do they hold? And those conversations may happen in some of those formats that we've talked about, or they may just be included as a paragraph within a GP letter shared with those services that are supporting that individual. When it comes to dying with neurodegenerative conditions, the dying phase can be quite rapid. It isn't uncommon to see a sudden death, and that almost reinforces why these conversations are so important, because death may be unexpected, but it shouldn't be a surprise necessarily. There are lots of tools out there that can be used to try and give indicators of deterioration, and some of these in the SPICT tool I've just pulled out here, they're relatively generic and they're relatively rapid in terms of decline, but they are an indicator. But in terms of the real world in MND, it's often that experience that people develop, having seen people more than one person living with motor neuron disease, and many GPs won't see very many patients. So it is that experience that those specialists and semi-specialists will be able to bring to it. We know that most people who die from MND die very peacefully, which is a reassurance. We can say with confidence that people do not die from choking, which is often one of the anxieties that people can have. And some of the clues when I'm seeing patients, I will listen to their chest. I will want to hear what their respiratory function is like. That silent chest is a real indicator that things are changing. Looking for patients who are fatiguing more. Patients may well not give that typical picture of dying that we can think about, but the more people you see with MND, the more you will get that sense. And that clinical instinct is really important to hold on to and feel confident in. If somebody is deteriorating more gradually, it's important to remember some of those natural elements of dying, that if somebody is, for example, having artificial nourishment and artificial fluids, we might need to mirror the natural process of declining appetite and declining desire to eat and drink by cutting the amount of fluid and feed that somebody's having, which is just mirroring those natural signs that we would see that obviously that person isn't able to express because they're having those artificial measures. And just to finish, really, I would just extend a bit of a call to arms, I suppose, in terms of that research portfolio, because alongside that incredibly important work around trying to find a cure for this wretched condition and slowing progression, we also need to make sure that we're expanding the palliative research portfolio, that we are managing the symptoms that people are living with now as well as we possibly can, and trying to document our experiences collectively. These are just a couple of studies recently that I've pulled off. We've got colleagues in the neighbouring county who are taking forward some work around choking. So there's a lot to be done, and the more that we can share our experiences, hopefully the better we can create experiences for those who are living with this condition in the here and now. Thank you. I'll hand over to you, Judy.
Good afternoon, everybody, and thank you, Ruth, for inviting me to talk today. My name's Judy Newton, for those of you who don't know me. MND nurse consultant and deputy director here at the Anne Rowling Clinic, which is anchored at the Edinburgh Royal Infirmary. I've been nursing people with motor neuron disease since 1998, so hopefully I'll be able just to run through, give you some top tips, but also just to hopefully thread together Pablo and Emma's talk. And one of the things that Emma mentioned there was your clinical instinct, and it really is honing into that. The more people you can see, the more practiced you will get. And there's a couple of things that you'll start to see repetition in patterns of behaviour, but that can also help inform you in your practice. So, and unfortunately my university doesn't allow me to access on Zoom, so I do have to go with the next slide, so apologies for that. So next slide, please. So again, Emma's also mentioned the 2016 NICE guidelines that have been updated in 2019, and there was actually very little upgrading of those standards and guidelines, and certainly we use them widely in Scotland as well. We don't have anything differently, so care throughout the United Kingdom should be standardised. And as you can see down here, there's actually quite a lot of recommendations, including coordination of care, and so that early recognition referral, and also assessments of your patients. So next slide. So the interdisciplinary management, again, a lot of you will be from a varied allied health professional background. Motor neuron disease is not just nursing, it is not just medicine. We look upon a whole host of allied health professionals to help manage, and everybody should be able to be confident in that ongoing assessment of their patients. I can't stress that enough, is that every time that you will see somebody, you should expect to see some form of deterioration. If you see somebody in maybe sort of 4 or 5 months and there's no deterioration, it's certainly worth flagging that back up to the neurology team to say, actually, have we got the diagnosis right? But by rule of thumb, you should be expecting to see some kind of deterioration in your patient sitting in front of you. And as you can see here, at some point in the person's journey, they will expect to see some of these people. One person I looked after had 33 allied health professionals at some point in their journey. But that's a lot of people that they need to see, and that just highlights the complexity of the condition that we are facing with. So next slide, please. So within MND nursing speciality, and I'm just going to talk to this because that's what I've been asked to specifically talk to, it really is down to the rapid clinical assessment of your patient. So that very first time that you're being asked to see somebody, how can you quickly assess what is going on? There are some nice tools out there that I would urge you to, if you don't already use them, start to have a look at, because these are your friend. If you can assess the rapidity of the disease in front of you, the level of dysfunction, the time scale that we're dealing with, it can then help you plan that person's care and the speed that you need to work towards for that. And certainly the way that I break things down is looking at people's cognition, their function, their staging, and their respiratory function. So the next slide, please. So clinically assessing your patient, again, you can find out a lot. If you have got the ability to sit in with your consultant neurologist, either at that first appointment or any subsequent, it's really helpful to observe that clinical examination. Because what you can pick up on is some early signs that might not yet be manifested in any issues that they might have. So they might pick up that there's an early fasciculations, for example, in their arm or in their tongue, but there isn't yet any dysfunction. So again, you could start to plan ahead. And actually, one of the things that we as MND nurses throughout the United Kingdom are planning ahead around about 6 months, looking at interventions. When do we start to talk about gastrostomy? When do we start to talk about non-invasive ventilation? When do we start to talk about the wheelchair, the voice banking, things like that? So the sooner that you can get on top of those, the better. And we're also all faced within the United Kingdom with emerging difficulty of NHS services and also community social health and care. It's taking us 18 months, for example, in parts of Scotland to get a ramp. That's no good. Our patients haven't got that amount of time. So the sooner you can plan ahead with your families, the better. So you can learn quite a lot from your medical colleagues or from any other professionals that you are. Again, sometimes we double up with speech and language therapists or our physiotherapists again, and you can work together in pairs. The way that I sometimes like to look and assess somebody is to go right back to that very beginning point. Ask them, when did this all start? When did you notice that something wasn't quite right? And work out in months how long it has been until that manifestation has really become to a point of disability. Is it 3 months? Is it 2 years? Because what we tend to find is that trajectory of decline doesn't really slow down. You tend to have somebody who's a slow burner, or you tend to have some people that what we call are rapid progressors. And those rapid progressors will continue to be rapid progressing, and the slow burners tend to continue to be slow burning as well. So that's quite a helpful thing, just to work out actually how long has it taken from that first problem to actually where you are at diagnosis. And then equally within that is how many domains can you actually work out are affected. So of those 5, cognition, upper lower limb, speech, swallow, have you got affected? So have you just got a one dodgy hand that's taken 2 years, you've got a slow burn, or have you got 5 areas of the body affected within 3 months? You've got a rapid progressive case, and you need to really be on top of that. It's also very helpful to understand the type of motor neuron disease that you're dealing with in front of you. Is it a primary lateral sclerosis versus an amyotrophic lateral sclerosis versus a bulbar palsy, for example? So again, really understanding that neuropathology, and again, your consultants will be able to help you with that. That gives you an idea roughly of timescales as well. And again, I'd be happy to go over that with anybody at a later date. So again, the more that you can clinically assess your patient and really start to understand what is that MND, and no 2 people will present in the same way, which again is what makes it really, really difficult for us as allied health professionals to work. And you've got to form that team, form that web around that person, so that you're supporting exactly what it is that they're needing. So next slide, please. So one of the things that I would urge you, not only because it's the Edinburgh Cognitive Screen, and obviously I'm anchored in Edinburgh, and it was my master's dissertation, so there's my little plug, but Understanding somebody's cognitive and behavioural profile will save you a huge amount of time. This will take you around about 20 minutes to run in clinic. It can be done remotely. It can be done by telehealth if you don't have time to bring the person up. But by understanding somebody's cognitive profile, you'll understand how much information that person can take in. Because if you establish early on in somebody's disease progression, i.e. at diagnosis, that they have got an executive dysfunction, then that will really impact on their decision making. So you can go blue in the face saying that I really recommend that you have a feeding tube put in, I really recommend that you start non-invasive ventilation. If that person is unable to make decisions, if they're apathetic, if they have got cognitive decline, you're not going to be able to help them make those decisions. Now, by having a cognitive impairment doesn't mean that they're demented, and it certainly doesn't mean that you don't and cannot offer them anything. It means that you can help work with that person. It means that you can advise the palliative team, the speech and language team, that they've got a language difficulty, that they find interpreting written or spoken words with difficulty. So it means that you can really hone in specifically on that single person's motor neuron disease, or cognitive and ALS and behavioural dysfunction, so that you can make the most of that, because our executive function is really, really crucial for making these rapid decisions, and especially some of the bigger decisions that Emma was talking about earlier for end-of-life care. So it's really, really important, and actually I would say that this is one of the first, and if you have only got 20 minutes, this is one of the first things that you need to be doing with your patients. Next slide, please. So again, I think I can squidge through that, but again, just to make you aware that we reckon that over 50% of your caseload will have either a mild cognitive or behavioural change, and we usually see that at the beginning of their disease. It will not necessarily get any worse, but it certainly won't go away. And again, just remember, 15% of patients that present to a psychiatric team will have a frontotemporal dementia and will also develop motor neuron disease as well. And those people need to be managed in a very different profile setting as well. So there is definitely a cognitive impact with your patients. So finding that out is crucial to your care. Next slide, please. Excuse me. The other scale that I would recommend people start to understand is the ALS functional rating scale. And this is a scale of 48 points, looking across a number of domains. We use it in trials as an outcome measure, but we also use it clinically to understand exactly what that patient looks like. So 48 out of 48 is what we should all be achieving. And again, when your patient's dropping down into the 20s, you've got really quite an advanced patient. But again, if you're using that in conjunction with some of your other measures, you can see that your patient is starting to decline. And again, you can use this really quite helpfully as an open discussion planning. You can say, look, I've noticed that your speech is more disturbed today, that you're having difficulty with your upper limbs or your lower limbs. What is it we need to do to address that? So not everybody likes us to do screening on them, but actually if you turn it around and say, this will take me 5 minutes, but actually it will help me get the services that we need to you. That's what we want. We really need to keep these people in control of their clinical care. Next slide, please. So again, just to go over the ALS FRS revised, it looks at your fine motor skill, your gross motor skill, your bulbar and your respiratory function, and people can, it's actually what we call a patient rated. So you ask the people about how their motor neuron disease is today, and you'll get a score from that as well. But again, clinically, you can use it just sort of very subliminally and whiz through your patient caseload that way as well. Next slide. So practical approaches, key is early discussion. Everything has got to be upfront. Sometimes, I'm not sure if, I think it is probably across the United Kingdom, but I would call it sometimes a very Scottish man syndrome issue that we have, where people don't want to talk about things. They don't want to talk about them. They actually would say, it's more important you make sure that my wife's okay or my husband's okay. But certainly it's really, really important that you can talk about things as early on as possible. Sometimes I would say to somebody, if I knew that they really don't want to talk about it, is I'll say, we need to have a one-off discussion. You need to tell me what you want us to do, how you want us to look after you. And then that means I can help guide the team behind us or behind them, so that they can actually start to remain in control, because that's the biggest thing. Continually assess your patients every time. Go back and do that. What has changed since I last saw them? Has anything changed? If nothing's changed, that's great, but keep assessing your patients. Ask them to do a very simple sniff test for you. Can you sniff let me see you sniff. And again, if you do that from the beginning, you can start to do have a really good understanding of the respiratory function, and you'll be able to see that changing. Advanced care planning, as Emma's outlined, starts from day one. What is it you want? How do you want us to look after you? Where do you want to be? And as symptoms arise, start to plan ahead on that equally. Equally, certainly one of the things that we will say is we'll start to talk about it. We do have a cut-off, certainly here in Scotland, where if somebody's respiratory function is really quite advanced, we can't put feeding tubes in. We can sometimes put nasogastric tube in, but again, we have got to allow people that grace to say, you know, at some point it will become unsafe for us to do this as a procedure, so we need to be upfront. And again, I use the analogy of putting your winter tyres on the car. Like, let's be prepared. We know what potentially is going to happen for you. We can see that from our assessments. So let's just keep ahead of that curve. Next slide, please.
Judy, sorry to interrupt, just 1 minute warning, if that's okay.
Thank you. Yep, I think I've only literally got a few more slides. So supporting wishes, including people in research opportunities is really important. We know that from a lot of our PPIE involvement. Offering people access to trials, and also making sure people know that where there are some really good information, MNDA, clinicaltrials.gov, so signposting people. Just to let people know as well about some of the other things, so next slide, that I've been working with colleagues across the United Kingdom on is developing, so next slide please, is developing, could you just go to the next slide please? Is developing a UK allied health professional where we're working with the research teams as well as the clinical teams, so everybody's coming together. I do regular webinar seminars on training, so any of those outcome measures. I have to train the sites for the MND Smart, so I'm very happy for anybody else to join us. And please just email me if you want to join that. And it's really important that everybody is trained. In the next slide. Again, is also meeting all of our professionals across the United Kingdom so that everybody knows what it is that we're doing. We've just published in Scotland some MND nursing competencies, and that can be transferable across anywhere. And I'm looking at developing some kind of masters in PDP, which will be online and it will be free. And last slide, please. I'm here to help. I'm not just Scotland-wide. I'm very happy to help. As Pablo had said, actually, the bulk of our UK sites that do MND Smart are in England and Wales and Ireland. And I do training across those. So I'm very happy to train any teams. I've just trained the Guernsey team, for example, as well on an allied health professional basis. So very happy to help you. And thank you again for having me, Ruth.
Thank you, Judy, and yeah, really appreciate that. I know we've got a lot to go through in a very short amount of time, so thank you so much for that. And thank you, Emma and Pablo. We've had loads of questions, so I was just looking at what would be really helpful to have in this time. Pablo, one for you. In the scenarios of diagnostic uncertainty, what are the most important red flags we need to think or consider, and what to do when you're not quite sure?
Well, I mean, I guess it depends on the clinical scenario, but usually, you know, motor neuron, I mean, that depends on, if it is typical ALS, and it's often, you know, not difficult, but if it's sort of predominantly low motor neuron or upper motor neuron, then it's just important to rule out mimics. There's sort of a paper on mimics and chameleons, which I can put in the chat. But yeah, and especially if people don't, because it's a degenerative illness, so if people don't progress at a rate that you would expect them to progress, then it's important to going through the history again, re-examining them, and just think again.
Thank you. Thanks, Pablo. Emma, someone's asked, what is your approach to navigating these sensitive conversations on palliative care with the patient and with the family? What are the main things that you do which help to support them most? And how do you manage to the challenges. I just know that comes up quite a bit, doesn't it, in kind of how we navigate from neurology to palliative care. I know all of you have said the early conversations, but what do you think?
I think often it is just that honesty, really, and these are real conversations that people are thinking about. They're real issues that people are thinking about. They often don't necessarily want to touch their toe into the water, but it is reframing what we're trying to achieve, to understanding how they want, within the context of somebody who does not clearly want to be living with MND. They are living with MND, and we want to help them live. We're not here to help people die. And actually, I think often the focus is that palliation is around end of life care and is around the dying phase. And invariably, when we're having conversations about that openness of, okay, so what matters? What are the things that are bothering you at the moment? If we can improve those things, we can open doors in terms of confidence and actually restoring hope, which I think feels quite counterintuitive often, but it's enabling and being honest and open, putting your brave pants on a little bit, but also just being confident with it, that this is simply another part of the conversation. I suspect, if I'm thinking about some of the challenges, Pablo, that you mentioned about actually giving somebody a diagnosis, I think that's far harder often than necessarily being able to talk about some of the realities of then living with the condition once they've been told that that's what they have. You have to sound out your patients. You have to get to know them a little bit, and you will have an instinct over, again, how far you can take some of those conversations. And it's often broaching, stepping back potentially, but invariably it is just enabling some of that, those understandings of that individual person and what floats their boat, what matters to them, and conversations will evolve. I think the other really important thing is that it is a conversation over time, and the amount of people that I've known who initially would not think about having a PEG, not want to be doing anything particularly aggressive, and then as their condition progresses, they are more accepting of some of those interventions, and so being prepared to move with that person, revisit things at times, is also really crucial.
Yeah, thanks, Emma. Judy, a question for you. It's sort of coming from the audience, but I think what they want to know is, how is it best for teams to work together? So they're particularly talking about how do MND teams work with the community neuro rehab teams, but I know that also is within palliative care and kind of all the many different respiratory, gastro teams. I don't know, from your point of view and your experience, how you think this is best to navigate.
Yeah, so you tend to have either a lead person, so a care coordinator or a nurse specialist. So in Scotland, we have nurse specialists who manage every person, and they are integral in ensuring that communication is across that wider MDT. And absolutely, good communication is key, as making sure that people can access notes, and again, making sure that primary and secondary care can understand, so that if a patient bounces into secondary care from the community, are they able to see what that advanced care plan looks like? Is there merit in actually having patient held records, so that if they do have to come in, any conversations or ACP planning can be brought in with you if there isn't a communication across primary and secondary care. But usually there would be somebody integral in that person or that caseload that can then coordinate the care and make sure that the wider MDT is up to date. And then there's that two-way communication back, and it is bi-directional.
Yeah, thank you, Judy. That's a really good place to finish, actually. So I just want to say a really big thanks to Pablo, Emma and Judy for your contributions to this part of the webinar.